This is the panel that is not hot air. This is the panel about business that's unusual. It's the panel about doing things differently. It's about disruptive innovation. Of course, it ought to be the panel, as the Secretary-General Gutierrez said, about antimicrobial resistance. Because if we don't crack that, you won't get UHC. But as he made the point, I don't need to. So we have a very distinguished panel with, you will notice, gender balance. Hurrah! What I'm going to do is introduce them as I ask them to give a short introduction to their subject about what they've delivered. Because this is about doing things differently and how they have made a difference. And then, once they've done their 5 minutes each, we will open the discussion to all of you. That's why it's not going to be boring, because you get to ask what you want, and they're talking about things they've done, not want to do. So, I'm starting with Senator Kezo Takemi, who you've all seen already this morning. He leads for global health in Japan and has played a great international role. And the rest of his bio's in the book, so read it if you don't know him. He's worth knowing. He's going to address political innovation. Over to you, Kezo.
Thank you, Sari. The political innovation comes from not always the scientific progress, but come from the human wisdom. And also, I have to say that the many theoretical common sense cannot be the common sense in the real world. When we talk about the health policy making in terms of the universal health coverage, we have 3 levels at least: the global level, national level, and community level. I remember a couple years ago, we had a high-level, the health meeting in New York City, co-chaired by the Margaret Chan and Jim Yum Kim. And they reached agreement to start the joint research between them, the bank and WHO, for the measurement, joint research for the measurement and the monitoring on the universal health coverage. This is the start of us. And this is the very important start, because we do realize evidence-based policy making should be the key for our process to achieve universal health coverage. And then I really appreciate that the officials in charge of this measurement and monitoring, both sides, the WHO and the World Bank, closely collaborated with each other and finally publicized it. Well, I'm so pleased. But in this process, it's not such an easy process. You can imagine the coordination among the gigantic bureaucracy always faced very serious difficulties. I'm proud that sometimes the Japanese government just go between. You can imagine. And then facilitate the process of the joint research. But always we have to design. Those are the new and the collaborative, the relationships between the many health-related agencies under the UN systems. Of course, the WHO take a very core role as a normative institute. But the WHO alone cannot do anything to achieve the universal health coverage. The World Bank has the money, and also the UNICEF has the operational capacity to deliver the services to the child and health and the children's health. And then how we can design the global governance and create the driving force which can accelerate the process of the coordination at the global level. This is one of the subject we have to overcome. We are expecting to have the high-level the health meeting 1 or 2 years later, but in the future, I'm quite sure, and the Secretary General will tell us, we should have the quite super high level, the Commission on the Universal Health Coverage in the United Nations, which can be a driving force to formulate the really effective governance structure for the universal health coverage. And secondly, the national level, the same thing happened. Health ministers alone cannot achieve the universal health coverage, and the finance minister should collaborate each other. For example, the Jim Kim just mentions that the IDA 18 defined that the health as one of the priority subjects for. And then now that the recipient government who can utilize the financial resources of GFF can automatically withdraw the additional financial resources for the IDA's money. Now, the window of each recipient government is not the health minister, finance minister in charge of this IDA's money. Therefore, health minister, without the finance minister's collaboration, cannot withdraw the financial resources from the World Bank and GFF. This is the reality. How we can encourage those at the country levels, the coordination among the ministers in charge of health. Therefore, in addition to the global and country and finally the community levels, the civil society participant is decisively important. Without the civil society and the private sector's collaboration, the government only cannot deliver the real efficient services to the people who really need. And then, how the different level of the decision-making can create consistent policy-making process. And then we can mobilize most efficiently domestic resources and the global resources for their own country's process to achieve the universal health coverage. This is not the dream. This is the real subject we have to overcome. Thank you.
Thank you, Keizo. So you can see real leadership and an emphasis on getting rid of bureaucracies and taking action. But now we turn to His Excellency President Lagos, who was President of Chile from 2000 for 6 years and is here as a member of the Elders. And what you're going to hear is a story of leadership, how he took his country with him and has changed it as a result. Ricardo.
Thank you. Thank you very much for this invitation. And what I'd like to talk with you was our experience. Needless to say, what is the result of a public policy? Public policies means how are you going to offer the supply side, what the government or what society is going to offer with regard to health coverage. And the point is this: if you see the supply side, or are you going to see the demand side of the equation? When you talk about the demand side, then you're talking about the patient. But the patient doesn't appear normally in public policies. And the big issue is, how are you going to be able to combine a public policy that goes from the supply side? Here is what can I offer, and what is going to be the demand. And the demand is, I need to have a dialysis, I need to have an operation, I said a breast surgery in cancer, That's the demand side. If it is possible to define public policy from both sides of the equation, and therefore the human being is going to be also at the center of a public policy, and this is what I did in my government, in a sense to go from a right to health to guarantee that right to the citizen. And if that right is not going to be carried on, the citizen is empowered to do it. Can we do that with every kind of diseases? Or can we be open enough to say, look, we can guarantee with so many pathologies. At the very end, we decided to guarantee 56 pathologies that represent about 70% of the workload in a public hospital. It's easy to say here, but we went one by one, year after year. At the end of my government, after 6 years, 40% 40 diseases were there. 2007, now we have 56. So we went from a right to health to a guarantee. And this is a tremendous change because then, how many pathologies? Now, number two, what about financing? If you want to do that, there is no question. You have to measure what is the cost of an appendicitis. And therefore, you will need to have protocols. Otherwise, it's impossible to make numbers. And when you talk about protocols, then you have some problem with the physicians. You are going to tell me what I'm supposed to do? I'm the physician. Yes, you're right, but do you think it's necessary to have a scanner for an appendicitis? This is the kind of thing that you have to face. But this means that the political will is going to be at the center. Of course, the important person is the Minister of Health. But what about Minister of Finances? What about the drinkable water in rural areas? Oh my goodness, it has nothing to do. Of course, it has a lot to do. But who is in charge of drinkable waters in rural areas? Somebody else in the government. So that means that political will means that all the areas of the government has to be available to provide what is required for a real health reform. And the number of members of my cabinet that were together with me as a president, defining what they are going to do, that means political will. And nothing will replace political will. I'm not an expert on health. But nevertheless, if we wanted to have health coverage for all, the first thing is, what about the political will of the number one? And the number one is the Prime Minister, or the number one is the President, or whatever. Two additional points I would like to add to the very short introduction. The first one has to do with the new digital technologies. Until what extent those digital technologies offer a tremendous opportunity to what we would like to do. If it is possible, because of telemedicine, if it is possible because of the mobile eye, to measure hypertension and to measure diabetes, and hypertension and diabetes represent about 20–25% of all our problems. And if you can measure your own, you the patient, and you can send the information every day to the primary healthcare center, then you are ready. Number two, if it is possible to use these new elements in order to be able to advance in some other areas, of course it is. Number three, and final point I would like to say, and this has to do with the problem of antimicrobial resistance, because this is something new again. How many years we are talking about this issue, and how are we going to be able to process the issue? And this means talking with the Minister of Agriculture, and this means talking with so many people in some of the areas rather than health. In short, if we wanted to address the issue of universal health coverage, that means that we have to change the optical and going from the offer and the supply side to the demand side. To introduce the new elements because the new elements is going to be the answer. Final point. Aging of population has been the area that everybody talked this morning at the inauguration. But aging is here to stay and will remain. Until what extent the schools of medicine in today's world are preparing the right physicians for the future, all of us probably are going to die from a chronic disease in our bed. Quite a different for what is yesterday the situation in my country. Till what extent the family doctor is going to be back then, given the ages of the population? Final point, what about then for the School of Medicine, and what about the physicians? This is only for them to define, or this is also going to be a political answer to define, because changes are taking place very fast. And all of us will need to have a long-term view about the future, where we would like to go. And the first thing is to address that the important issue with regard to health has a lot to do with the patient, but the patient normally has no voice. And this is the rule number one. How are we going to be able to have a health reform that will listen to the future patient? Thank you.
Thank you very much. Truly inspiring, putting demand and patient need absolutely at the center, focusing on a blocker, which is my tribe, the medics, and amazing what your leadership has achieved. So let me turn now to Gitinji Gitarahi. Now, many of you will know he's the chief exec of Amref Health Africa. He's a medic who's been at that interface of public sector and private sector all his life and delivering real health gain, and on Monday was elected co-chair of the UHC 2030 platform. Over to you to talk about partnerships.
Thank you. First, I'm delighted to be part of the UHC 2030 because then that is the platform where we drive all the political will and share knowledge with everyone who is interested in UHC. And right now, we think that, and we know that all of us are interested in UHC. I would like to talk about, instead of wearing my UHC hat, I'll wear the Amref hat and tell you exactly what we are doing on the ground. Amref is working in about 35 countries in Africa, and we work at the community level. And for us, we strongly believe that the biggest stakeholder in universal health coverage, as has been said here, is actually the community member. Those are the biggest stakeholders. And they're not only stakeholders because they're the biggest beneficiaries and they're the ones whose lives we are worried about, but actually, in actual sense, they're the payers. They're the people who actually fund universal health coverage. How do they fund it? They fund it through their taxes. They fund it through their sweat. They fund it through their savings, through out-of-pocket expenditure. They fund it through their land by selling it to pay hospital bills. They fund it through their livestock by selling their cows and goats to pay for healthcare. And ultimately, they fund it through their lives when they actually lose them. Ultimately, it's the ultimate sacrifice. But they remain also, as His Excellency, the former president of Chile has said, they remain the least engaged. So the question we've been asking ourselves at Amref Health Africa is, how do we engage the communities? And I think for me, when you talk about innovation, partnerships, the most important partnership and the most important innovation that we can do for universal health coverage is to engage the communities and to empower them. Technology then becomes an enabler of that process. But the real innovation, surprise, surprise, 40 years after Almata in 1978, the real innovation still remains engaging and empowering communities. How do we do this? Because first, we have to tell the community that there's no free healthcare. They pay for it, as I've said. Even when we talk about free healthcare and we say free services, I think we actually disenfranchise the community because we make them believe there's someone else paying for this healthcare. When we say, it's free for under 5, it's free for this, it's free for this, it is actually tax-funded healthcare. And the taxes come from the community. So we first have to empower the community to understand this concept, that everyone is a participant. And when they understand that, they then demand for it. The danger of telling them it's free in UHC is that therefore they wait for it to be given as a privilege. Whereas when you tell them it is actually you paying for it, then you empower them to demand for it. And that's a very powerful concept for the public, to understand they're paying for it, therefore they have to demand for it, understand that health is a human right and they have to actually demand for it. Number two is also participate in supply side financing and planning. They have to participate in budget. Now, what are we doing about all these things? I want to just focus on one example of what we've done, and I'm sure that there may be probably questions after this. What we've done as AMREF is gone to the community and ask ourselves, there are certain challenges. Tax side, which supports supply side financing, is okay. The government is doing that. They can educate the people. But what about pooling of resources? What about pooling of protection? What about getting the communities to participate in all these schemes we are talking about? In most of the countries where we work, actually in all of them, the informal sector is big. Only a small percentage of the people are in the formal sector. Therefore, only about 20% of the population participate in formal taxation for NHIA, for national health insurance schemes. How do we activate the able communities who are not in the formal sector? We asked ourselves this question and we said, what if we actually used community health workers to do this? And what if we gave them technology to enable them to achieve it? So we went to one of the counties in Kenya and we said, we talked to the governor, because again, you need political will to move this, and the government, and we said, let us convert the community health workers or community health volunteers to health insurance agents, to UHC agents. So because they live with the community, they are trusted by the community, let them go day by day, convince households to actually pay premiums for national health insurance, those who can afford, identify those who cannot through collecting socioeconomic data from the community, handing them over to the government for subsidy, but those who can pay, making sure they contribute month by month. So far, we started this a month ago, we have 4,000 households already registered for universal health coverage in this particular county. Over half of them have already started paying their premiums. A small percentage have been identified for subsidy, and that 4,000 is 4% of the total household population of that county in a month. It can be done if we invest in creating an empowered and engaged community. And the best tool is to use community health workers and enable them with technology. Thank you.
Thank you. Thank you also for giving a real example of how to do it. So there's a theme here about community involvement and the demand side. So as I hand over to the women, let me hand over to a patient, Cecilia Rodriguez, who's a social communicator and works particularly in the chronic conditions of rheumatism. Cecilia.
Before my time starts running, I need to add that when we need to put face to policy, public policy, and I'm the face of the public policy of my country. I live with a chronic condition and I should pay $1,000 for my treatment. Today, for the policy making that we had in those years and the last law that was passed, I paid $10 for my treatment, and I could stood up from bed and I can be here and working for patients. So I never met President Lagos before, and this is a good moment to say thank to this policy, public policy. So speaking about chronic conditions, this is what's coming. I know health is much more than a chronic condition, but this is what we need to start to address. And what is like living with a chronic condition? There's an issue that's very important. 99% of the time, people who live with a chronic condition are away from the health systems. If we go to a physician, to a doctor, to a nutritionist, it's only 1% of the time of our life. So, if we keep working only with the health systems, we are missing 99% of the time where people take decisions that impact directly on their health, directly on the health system back. But we are not working there. Also, living with a chronic condition is not only about the disease. It's not only about having flares, in my case. It's about dealing with how a chronic condition changes your life, changes how you need to work, changes how you make your family, social life. So patients know and learn by heart how is this management of the 99% and how is the management of all these other issues that you have to deal with. 2 examples. Sarah Rigare from Sweden, she was diagnosed with Parkinson when she was 32. She could only visit the specialist twice a year. She wanted to have the best medication scheme. So she started doing measures, and she measured herself. And she went to the doctor and said, look, this is the way we should manage my medication scheme. And now that's the way she managed her medication, and she's great, and she's a PhD in Karolinska Institute, and she's doing a lot for patients. Sebastián Castro, back in Chile, he was diagnosed with inflammatory bowel disease, and he was struggling with, for me it's so hard to understand how to manage this, how it's for a kid. So he wrote a book, and the book is now a cartoon. And they are using it in Argentina, and now civil society and patients' organization are translating it to English. What we learned from this: patients, no matter where you are, have the same concerns and the same problems when it comes to manage chronic disease, and no matter what is the disease. There's much knowledge, experienced knowledge in patients, but we are still the outliers of the system. What we learn doesn't come back to the system to get better quality, more efficient system, more people-centered. We are advocating to have innovation centers, patient innovation centers. Let's make it real. Let's make real people-centeredness. Let's have patient innovation center where we can build relations between academic knowledge, expertise knowledge, experiential knowledge, entrepreneurs, and solve problems, real problems. We have the half of what is needed. We have the problems identified. Now we need to build solutions. And the most important, we need to bring this solution back to the system so we really can talk about quality, efficient, and people-centered care delivery. Thank you.
Thank you for grounding us. That was wonderful. And you're right, we do need to listen. So let me turn to the last panel member. But before I do, when Sander has finished, I'm going to open up this panel to all of you. So start thinking about the questions you want to ask the experts. Sander is head of corporate responsibility at Safaricom, and she's going to talk to the issues about the private sector and UHC. And it's interesting that you are the first person this morning from the private sector to talk to this issue. Yet we wouldn't have penicillin without the private sector. We wouldn't have digital or anything without you. We need you. Over to you.
Thank you. Well, yes, it's interesting in the last 2 days that I've been here that there hasn't been much mention of the private sector. Yet we're here discussing a very important topic called leaving nobody behind. Now, I think for the private sector, the Sustainable Development Goals provide a really good entry point. There's been a clear clarion call for private sector involvement through the SDGs, but I still do think it is a missed opportunity and an opportunity that really is not being capitalized on enough. You know, if you look at it, there was a recent report by the Business and Sustainable Development Commission that talked about a $12 trillion business opportunity for doing business within the Sustainable Development Goals. Again, I don't think we talk enough about it. Purposeful business has a great opportunity within the goals and within issues such as universal health coverage to really look at how business can help drive through products and services, through innovation and through technologies, key factors for the UHC agenda and indeed for the Sustainable Development Goals. There's a great saying, business cannot succeed when the society around it is failing. And I think that should really ring true to all of your engagements when you look at the business sector. And I'd say challenge the business sector because it's not about corporate social investment. It's not about doing good. It's about bringing business solutions, efficiencies, and opportunities into addressing this really important UHC agenda. So I'm going to talk a little bit about Kenya, where I come from, and two examples. The first is what we've done around building business sector coalitions. We've developed with the Ministry of Health, our minister is here, as well as under the leadership of the UNDP, a private sector health partnership. And what this has done is brought together about 6 companies, ourselves, Safaricom, which is a communications company, Huawei, that works in technologies, Philips, GSK, and others, to look at how we can impact the rising maternal mortality rates in the 6th worst counties in Kenya. And what we've done is brought together our technologies, our people, our products, and our services to deliver innovative solutions such as sustainable lighting, training of health workers, dissemination of information to help drive down maternal mortality rates. And it has already shown considerable results. But let me talk about what really excites me the most is Kenya and the mobile industry. So we are pretty well known for our mobile money. I'm sure you all know about M-Pesa. We've been able to bring on board, financially include about 80% of the Kenyan population. We have coverage of about 90% of the Kenyan population, so I say it's covered by mobile. Great strides, but what does that mean for an issue such as universal health coverage? To what extent can the ubiquity of the mobile bridge the gap around what we're trying to do in universal health coverage? So in the exhibition space outside, there's a fantastic product called M-Tiba, which I do think you need to go see. For us in Kenya, M-Tiba is the solution to universal health coverage. Using simple mobile phone, we're able to collect payments or premiums, we're able to subsidize premiums, we're able to provide medical data, we're able to provide patient data records, we're able to track treatment and link that to outcomes at the end of the day. Essentially, all through the power of a mobile phone. And I think for us, the capabilities that M-Tiba has brought has really helped change, at least drive an inroad into the provision of universal health coverage. Other technologies, in partnership with AMREF, we have LEAP, which is a platform through which we train community health workers. So we're able to provide and amplify AMREF's goal, which is to train, I think, 100,000 or so midwives and health workers. But how are you going to provide content to people that are so far spread out within the country? Through LEAP, which is simple mobile technology, we're able to do that. There's other technologies that help provide efficiencies to the supply chain, other technologies that bring efficiencies to agriculture and to education. And bridging all these together, I think, touches on all of the SDGs and provides immense opportunities to impact on health. So, from a practical advocacy perspective, as well as from practical business solutions, I do think that the private sector is able to contribute immensely to universal health coverage. What do we need to do different? Because there is a lot. I think we need to not fall into the trap of over-engaging into pilots and experiments and figure out how we need to interoperate across technologies and go to scale. For me, that would be the first. I think the second is that we also need to partner differently. How do we speak the same jargon with entities such as the World Bank, the WHO, yourselves in this room? What is the common platform that can bring us together? But without that, I think that we'll be missing out on significant opportunity to have private sector involvement in this very important agenda. Thank you.
Thank you for bringing that important voice into the room. So now it's your turn. Who'd like to ask a question? What weeds? Think about it, folks, while I ask our colleagues here if any of you would like to give us some thoughts about innovations from outside the health sector and how they can accelerate progress to UHC. Because apart from now, we've been talking about the health system and the financing and the need for others to come in. But there are other innovations. Who would you like to, Sander? And then Ricardo will come in.
A lot has been said about nutrition and its important role in delivering on health. Yesterday, we had a really passionate speech by the head of World Food Programme. So, typically relief food is distributed as a certain set of nutrients, often it's, Unimix and others, right? But what does that do in terms of improving a refugee's nutritional status? It provides the basic, perhaps doesn't necessarily provide a wide range. Again, what we've done using mobile money with WFP is actually stop issuing relief food and issue e-vouchers. And what the e-voucher does then, it allows the refugee actually back their dignity. With the e-voucher, you're able to translate that into cash and then purchase foodstuffs. And it's locked in a wallet, should I say, that only allows you to purchase foodstuffs and nothing else. But it gives you back, number one, dignity. Secondly, it creates empowerment because small businesses have now sprung up. And thirdly, it creates choice. And I think with those three, WFP has been able to really transform how its whole relief food response is carried out within 2 main refugee camps in Kenya, Kakuma and Dadaab. But more importantly, it's also changed the nutritional status that then goes and impacts into health. And for us, I think that's been a really important driver of then how other agencies, UNICEF and the rest who work in the camps, come in and deliver the essential services that are critical for UHC.
Thank you, and thank you for putting it back to impact. So, Your Excellency?
Yeah, I would like to follow what you mentioned about the private sector. In most of our countries, you have a private sector and a public sector. In my country, it's about 20% in the private sector, 80% in the public one. But if you're going to have a health reform, you have address to both sectors. This is essential. You cannot have one only for the public or for the private. All of them should be in the same boat. If you're going to guarantee for everybody. And this is essential. At the beginning, it was not very difficult was extremely difficult to understand by the private sector, but finally they understood, and they are part of the whole issue. Number 2, needless to say, the private sector has much more per capita income put in, et cetera, et cetera. That's normal. But nevertheless, the fact that you go to guarantee, the guarantee for everybody, you are not going to make a distinction. Number 2, I think that what you mentioned with regard to the participation of patients in the definition of public policies, when you're going to see from the demand side, is essential. And I think that the new technologies allow you to have that kind of participation and to listen. Number 3, I think that with regard to these new technologies, it's going to be possible to have just one national register of pathologies and medical elements of each citizen in a country. And this is essential, because if you have that, with just one finger, you can have all the history of a particular citizen. And this is essential, not only in order to make sure that everybody is going to be taking care of what is the register, but it's essential also if you belong to the private or to the public sector. And this, I think, who is going to be the owner of that? Obviously, the patient. In other words, I think that how long will take that in each of our own society, till the moment of birth, till the moment that you die, is going to be just one register, and I think this is going to be a tremendous step forward if we wanted to use the new technologies and to have participation for everybody. Thank you.
Thank you. Inspiring again. Githinji, and then I have a question at the front, one at the back, and one in the middle.
So I'll make this very quick. In our partnership with Safaricom in developing the community health worker platform, which Sander called LEAP, one of the questions that came up front was, what is the future business model for this app, for this platform? And even as Safaricom invested, we had said, fine, it is doing good, and therefore we're going to invest the initial capital money, but what about the future? So right now as we speak, this platform we developed with private sector, which again came from outside, it's about the mobile phone. It was not innovation in healthcare. is now training over 40,000 community health workers and was recently used in disease surveillance. Because again, the biggest challenge in disease surveillance is about having people next to the community who are able to notice syndromically that there is something going on, that there are children with jaundice, that the rate of diarrhea has gone up. And using this mobile phone from the telecom company, they are able to notice that and take up the message to their supervisors and finally the Ministry of Health. And we're able to manage. Recently, we managed a cholera outbreak in Kenya and a dengue fever outbreak in one of the other counties very seamlessly because of this technology, which comes from the telecoms, but now applied in healthcare. Most importantly, think about sustainability in future. But it is possible, and we have seen great success on that.
Wonderful example. Thank you. Victor.
First, I really appreciate this panel, which really covers the whole spectrum of policy to patient-centeredness and social corporate responsibility. When I look at innovation, and we see some of them actually just now, many innovations and the proper ones coming from the ground level, that is small innovators who are actually looking at the demand side and being able to come up with solutions. Their biggest challenge is not innovation, but scale. Their biggest challenge is not only the creative idea, but how to actually get adopted by government systems. How does it become part of the protocol, if you will? And so I'd like to put this question forward to everyone. You know, while it's really nice to hear a lot of this creative innovation here and there, how do you actually eventually get to the point where there's sufficient, quote, evidence, there's enough, you can cross the valley of death, and actually scale to a level by which, in fact, policymakers says, this is going to be part of how we do things.
So one of you to answer this, because we've got 2 more questions. Who's going to answer? You are, right, and then...
I can take that very quickly, because we've actually considered this question significantly. Number one is that at the end of the day, when you talk about health sector, there is, the largest payer is government. So you have to involve them right from design. That's number one. That we've seen a lot of innovation that comes, people develop it up to the end, then you come back and tell the government, oh, this is a very nice innovation. And the government says, where did you start? And we have that experience with LEAP. The government said we have to go back to the field and evaluate your innovation. So number one is involve the government right from the beginning of innovation and design. The next thing is that one of the biggest challenges to actually having scale is that a lot of the innovators are working outside the ecosystem. That's the biggest challenge. You have people who come in and they're in education, they're in engineering, and they have brilliant ideas, but they're working outside the ecosystem. So they will never scale. So what we are doing now as AMREF Health Africa is saying, we are working in 35 countries. We have programs of maybe about 150 projects funded by Global Fund and other multilateral and bilateral donors. How can we present them as an ecosystem for innovators to come on board and test their innovation within existing programming? So we have now created what we call Innovator in Residence. So if you have innovations, we bring you on board, we attach you to existing malaria program or maternal and childhood program, and you work with our staff and you test it, we link you to the public sector, so that when finally it's successful, it's easier to scale. So that's what I would say in response to your question, and it's working.
Thank you. Innovator in Residence, you heard it here. Cecilia, the citizen voice.
For us, it's so simple, the answer. It's like somebody needs to use it. Patients need to use it. That's the only way to scale it. Last night, I was talking to Sara Rigare. She's in Sweden, and she was talking to me about a new device for rheumatic disease that can improve your movement of your hands. It's not the system. We have to think of early adopters. And early adopters are patients around the world, and there's a patient movement, and we are talking to each other. But the system is not talking to us. So we need to talk back to the system so we can scale it bigger. That's one thing. And another thing that from the question before about data and health record, it's so important. We all the time we speak about empowerment and community empowerment, patient empowerment, and health records are closed to patients in almost every part of the world. If health records are not open to patients, we cannot be empowered, and there's not another way.
Thank you. 2 questions, both short, I hope. One at the back, Nigel, make it short, and then one down there.
Thank you, Sally. Very simple point. The most important people in universal health coverage...
A question, please, Nigel.
The most important people are people. So what do the panel think about innovations in human resources, whether it's about training or about entrepreneurship or about the relationship with technology?
Thanks, Lord Crisp. Yes, second question, and then I'll pass over here.
Robert Yates from Chatham House. Universal health coverage is all about the rich subsidising the poor. I mean, it's the only way you reach universal health coverage, and compulsory public financing is the answer to that. So I'm just wondering about this modern technology and people using mobile phones. How are you ensuring in Kenya that you are having the subsidies? Because it doesn't sound as if there's much pooling involved. Do you have higher tariffs for people with fancier phones or something?
So, Sander, open to all of you, but let's start with Sander on these two questions.
Right. Okay, so the first one on the investment on human resource, I do think that's absolutely important. Again, if you look at a country like Kenya and look at where the need is primarily at the primary healthcare level, for us it's solutions such as LEAP, again, that Gideon just talked about. We're able to train community health workers in a way that makes sense to them. So using, again, simple, feature phones, they're able to provide content, they're able to connect with supervisors and units, etc. For us, it's very much about how you can bring efficiencies to a pretty much, community-based health system as a whole. Of course, there are more Rolls-Royce solutions up there when you get into telemedicine and other things like that. I think we're just focusing our energy on our partnerships and how you can really impact at the primary healthcare level as a whole from that. To the other gentleman that asked about what we do on pooling. So MTIBA is actually in the exhibition stand out there, and have a chat with them because they'll give you a lot of detail around it. But essentially, we're again looking at it as a public health sector solution. We're hoping to link into the National Hospital Insurance Fund and work with them a lot more closely as a way to first register patients, get premiums in, and then from there link into the overall service provision through the public sector. So it's not necessarily a tool for more higher income people as a whole, but it's really about how we can bring inclusion into the system. We have 30 million subscribers out of a country of 45 million. So 30 million people have a mobile phone in their hand. 20 million people use mobile money. If we're able to use the simplicity of mobile to get people to register into a platform, to get premiums or subsidies paid into them, we feel that we'll be able to include a lot more people into the health system as a whole. That's really our starting point.
Thank you. I'm going to hand over to Your Excellency next, but Cecilia, you are going to get the last word and say whatever you want. So, Your Excellency.
I myself recognize that there's so many the scientific innovation can be closely related to the health system strengthening to achieve the universal health coverage. However, only a market mechanism we cannot so absorb those the new, the scientific, the progress and the innovation into our own health system building. Who can do it? The policymakers at the central government and the government officials of the local government. And those guys should have enough knowledge and strong the willingness to absorb the scientific innovation in collaboration with the potential partners of the private sectors, including the industries. And then they can mobilize the resources to strengthen their own health system, to deliver the good services to the people who are really in need in the community level. Therefore, the important thing is those are the governabilities and the capacity of the central government and also the local government, which should be the key to mobilize the private sectors, the wonderful scientific innovation. Therefore, when we talk about the health system strengthening as a part of the process to achieve the universal health coverage, we always simultaneously have to take into account the governance structure, which can be suitable for the new challenge. Thank you.
Thank you. Your Excellency, President Lagos.
Well, what I would like to to say is that in addition to the political will, till what extent you are going to be able to build some broad agreement in the society with regard to the changes that we'd like to include. In other words, if it is possible to go beyond the public and private sector, or is it possible to go beyond the different left and right wing coalitions and the political scheme. If you wanted to go from the supply side to the demand side, and you go to listen to the patients, if it is possible to have a general agreement and what this means with regard to the future of the health reform, until what extent you will have a very broad coalition in order to be able that these reforms will remain on time. Otherwise, with each election, if you transform the issue of health in a political issue with different antagonistic sectors, it's going to be extremely difficult to have really a global reform on health that will remain. If you don't have a long-term view, it's going to be extremely difficult. And this requires political will of different sectors of society. It's very easy to say here, it's much more difficult to implement right on the field. Thank you.
How very true. Githini, 2 last sentences.
I think the last thing I would say is that in all this discussion, you notice the importance and the pivotal role of civil society. Because if we are discussing community mobilization, and we are discussing trust. We are discussing trust as the currency of engagement, because the communities need to trust you for them to allow you to engage with them. And this currency of trust is something that actually is highly owned by civil society. And I think in the whole discussion of UHC, civil society needs to be central to that discussion, needs to mobilize communities, then link them up to the government, and then as we continue to then mobilize the political will that is needed to support the policy frameworks that are required to achieve that. So I'm calling for more engagement of civil society, all the way from the government down to the community and back up.
Thank you for bringing in trust, so Cecilia.
So, NHS recently defined a patient leader as an individual whose personal experience have led them to instigate change and, as a result, shape healthcare. Those are the leaders. Not everybody has the ability to deal with problem solving. So we need to enable patients and give them the ability to solve problems and give them skills to partner and to innovate. So look for the patients in your countries, for the patients' leaders. They will bring more patients with them and no more patients as outliers.
Thank you. So as we come to an end, too rich to summarize, so I won't, but I will rectify protocol. I should at the beginning, through you, Senator Takemi, have thanked Japan for hosting this and for your leadership in UHC. And please join me in thanking this extraordinary panel for all the depth of thought they've given us today.
All right, thank you very much. We have lunch in the same place as yesterday. Be back here by 2:30 for the next panel. And if you haven't yet seen the Innovation Showcase, please visit it. Right across the hall. There are some really fascinating exhibits there. We'll see you at 2:30.